Assalamualaikum warahmatullahi wabarakatuh. Bismillahirrahmanirrahim. I am Dr. Sani. Okay. I would like to introduce a speaker for our lunch symposium today. The topic will be apnea ventilation, and this lunch symposium slot sponsored by Dr. Gas Medical Sdn Bhd. Dr. Shahridan Fathil is an esteemed consultant anesthesiologist with a rich tapestry of experiences and contributions to the field. Dr. Shahridan, a Malaysian national born, boasts an impressive academic background, holding an MBBS from University of Malaya and achieving fellowship of Royal College of Anaesthesists in June 2003. Currently serving as a consultant anesthesiologist at Gleneagles Medini Hospital, Johor, Malaysia since April 2017. Dr. Shahridan has not only excelled in clinical roles, but has also assumed various administrative positions, including chairman of the Medical and Dental Advisory Committee. His extensive affiliations, including past roles in executive committees for society like WinFocus and Austria PM, reflect a commitment to advancing the field. Dr. Shahridan's research contributions, numerous publications, and role as a speaker and faculty member further underscore his dedication to medical education and the betterment of patient care. In summary, Dr. Shahridan Fathil stands as a distinguished professional, blending clinical expertise, leadership, and a passion for advancing medical knowledge. Without further ado, welcome Dr. Shahridan to share your presentation. Thank you.
Thank you very much for the kind introduction. Assalamualaikum and a very good afternoon. We are still sorting this out. So my topic today is actually apneic oxygenation, slightly different from the one listed in the... Okay, I guess it's a challenge to talk without the PowerPoint. So may I know how many of you guys are doing, particularly for your ENT surgeries, do you do tubeless anesthesia? And put the high flow on, high flow nasal cannula, and don't tube the patient until the surgery finishes. Anybody of you doing it now? For particularly laryngeal surgeries? Oh, that okay. This is so I can talk freely. Okay, thank you very much for your patience. And patience is a great virtue. I know some of you may have been out. Hopefully they could come in. Okay, so I know I'm a barrier between you and lunch. I will finish this within about 10-15 minutes or so. Okay, this is where I work at the moment. It's a small private hospital. We're about 5 functioning OT at the moment. But we do about 600 cases a month for the past few months. So we do see quite a bit of tertiary work. And I like to think we do quite a bit of regional anesthesia. This is my colleague, Dr. Ng, who's doing an ESP block for post-thoracotomy patients. So we had most of the surgeons that we work in are very receptive of our regional blocks, and it's been for most of the subspecialties, surgical specialties and specialties, we have actually been doing quite a bit of regional anesthesia. We do, as I mentioned, we do quite a bit of tertiary work. So you could see this is our standard monitoring for each and every patient, but no, I'm just kidding. Of course, the outline and CVP only comes when they are risky patients, but we do quite a bit of anesthetic depth monitor. You can see BIS there. So technically we are 80-90% TIVA hospital. So we incorporate that, and we seem to have, it enhances our turnover time, better emergence, and less nausea, vomiting. But we also do quite a bit of neuromuscular monitoring, neuromuscular function monitoring at the NMT, particularly because we use quite a bit of rocuronium and sugammadex. And so this is just to highlight what we're doing now. Again, with regards to affiliation, I am a member of the SIGRA. And tonight we will be having our first AGM of the Malaysian Society of Regional Anesthesia. So disclosure, I have been, this is sponsored talk by Diachorgas, the distributor of the Fisher-Paykel high-flow nasal cannula, and I am using honorarium for this particular talk. Bit of introduction. We know now high-flow nasal cannula has been over the last decade or so is a popular option for respiratory failure. There have been the clinical indication is as listed below, and the difference is with the high-flow nasal cannula is that it has humidification, and it is of course by the fact that because it's nasal, it has a better tolerance for the patient, and the patient is able to continue to eat and drink while the therapy is ongoing. Okay, there's a whole long list. I'm not going to go into great detail because probably it's not so much the emphasis of this talk. So, you know, it ranges from acute hypoxemic respiratory failure right up to post-extubation and respiratory procedures, which will I highlight to in the last part of my talk. Okay, and this is another review article. Again, similar benefits of high-flow nasal cannula. Okay, and we know this, that these are the roles that have been proven. This was a 2020 ICM article, and we know that there are some which is probably strongly recommended. Okay, so definitely there's some conditions, for example, hypoxemic respiratory failure is recommended or strongly recommended by this this CPG committee. And probably in the peri-intubation period, at least by this group, there's no recommendation. Okay, so this is just a slide I took while I was volunteering in Hospital Mizan. This was their car park basement, which they're converted into a makeshift COVID ward. So we know that with COVID, we use more and more high-flow nasal cannula. This was actually a patient where we intubated, had difficulty in oxygenation. Eventually, a patient walked out of hospital. So, you know, we do have some success stories when we were dealing with COVID patients. And this was in Labuan Field Hospital, where I volunteered as well under Mercy Malaysia. So these are the things that we use, you know, the prone positioning and high-flow nasal cannula is the new stuff, I would say, modalities when we're dealing with hypoxemia, hypoxemic respiratory failure. Okay. So even if we got to evidence, this was 2020, but you can see that there was probably not so convincing, but eventually in 2022, when they were looking at all this evidence and they were showing that actually there is strong evidence for for the success of high-flow nasal cannula in COVID-19 pneumonia. Okay, now we talk about apneic oxygenation. How many of you guys do scuba diving? Ada satu, okay. This is not adventurous bunch. Okay, ada dua tiga, the ladies. So we're going to talk about, any of you do free diving? Free diving, tak buat? Okay, tak buat. Okay, so basically this is a video I took when we were doing training free diving of my son. I don't know whether it's going to play or not. Okay, so technically, if you train the human body, we can be apneic for 1 minute or so without having to have any issues. So this was actually this was the license. So my son was going down, I think it was 18 or 20 meters, and then up back within a breath. So this is what we call apnea, apneic diving or free diving or whatnot. Okay, so I won't, okay, so in the interest of time, I won't show the whole thing. Okay, so, okay, I know this is going to be a bit off. Yeah, this is what happened when Mac and basically when the PowerPoint between Mac and PC. But technically, one of the first descriptions of apnea was 1946, where there were apnea ventilation, where patients or dying patients with head injury were actually basically put apneic, and the patients did not desaturate until about 2 hours or so if we are given adequate flow through the ETT. Okay, this was another one in Nature in 1951. Okay, I won't go into great detail. Okay, but what happens when with regards to high flow, in a patient who is apneic, when they are not actually, doing proper inspiration, expiration, when there is enough flow and in fairly normal lungs, there is actually this mass flow of oxygen, which continues to replenish the the actual O2 or the FiO2 in the alveoli. And when this continues, there'll be a maintenance of the actual PaO2 and SpO2. But of course, you can't keep doing this for a very long period because of the fact that when there is no ventilation, there'll be CO2 build up, and this CO2 will increase the capital AO2, and this will result in desaturation. Okay, the first description of actual apneic oxygenation was actually by Levitan, emergency physician. And this was actually when I tried to look at the actual publication, it was actually in this newsletter, emergency medicine newsletter in the US. So no DSAT, nasal oxygen during efforts securing a tube. So technically, what they propose is that the patients who are intubated or who are going to be intubated in the emergency department will be put on this nasal cannula, nasal prong, and of course the liters for most situations will be only about 15 liters per minute. And there is actually data to suggest, this was a 2011 by the same author, Richard Levitan, and he is suggesting that actually during the intubation period, leave the nasal cannula throughout the airway management period to maintain apneic oxygenation. And this was a meta-analysis published 2017. I won't go into great detail, but most of the studies included were actually low flow, technically up to 10 to 15 liters. There was only one, which is actually high flow. Okay, but they managed to conclude that there is actually, when the patients are put on apneic oxygenation, and in majority of the studies were actually low flow system, that they do prevent desaturation and also promoting safe apneic time. So we kind of know at this point, even with low flow systems, that when patients are undergoing some form of tracheal intubation, that we can actually improve safety. Okay, this was a 2017 publication by Patel, where he documented the use of in 25 patients, a series of TRIVE, which is transnasal humidified rapid insufflation ventilated oxygen, technically using high flow system, which we know now the high flow nasal cannula. And this is what he used. And what they managed to actually document is that they can increase the apnea time. These are patients who are undergoing laryngeal surgery, and they are not intubated, and the patients do not desaturate up to 20 minutes to 30 minutes. Okay, this is similarly shorter. This is adult patients, 31 patients in the short laryngeal surgery undergoing general anesthesia similarly. And I think, yeah, there's a bit of, a bit off in terms of the crop. So they've also managed to actually prove that, that the patients can be apneic for a long time and they can be safely apneic without any desaturation. Okay, one particular suggestion is that when you are intubate, you want to improve the apnea time is actually to pre-oxygenate them. And this, I find this true with my limited experience as well, that if you put the nasal prong, the nasal cannula on top of the forehead and pre-oxygenate like normal, and once you induced apnea, whether, and paralyze the patient if the patients are for paralysis, then you can immediately put the nasal cannula on top to the nostrils instead of having to waste time to actually put it on before. So this is a technique that I find quite useful. And they've been basically showing studies to show, this is just a documentation looking at 25 versus 24 patients, where the patients, this is hypoxemic patients undergoing intubation in the ICU with high flow nasal cannula and without high flow nasal cannula. And this is something that they did, which actually they incorporated also NIV, something that you guys probably, when you're dealing with hypoxemic patients, NIV these patients, and once sedative and paralysis is being given, the patient is put on the nasal high flow cannula. And they found out that actually with a high flow nasal cannula, there's actually a better oxygen saturation compared to just NIV alone. Okay, this is also proven in children. This is a TRIVE study in children. I won't go into great detail, but there was randomized control trial for 48 children. And again, they showed that actually the time to desaturation is much longer with TRIVE compared to control. Okay, these are just ways of apneic oxygenation where basically you can see the cannula and the laryngeal surgery is being performed. Okay, there have been more recent documentations of the apneic oxygenation in this review article, and these are just the documentations of various studies. I won't go into great detail. Okay, how I came about to do this, because I was invited to speak at the ASEAN Congress in Brunei. This was 2019, and I heard from Imran. He was one of the invited speakers, and where he shared his experience in London, where he did all these laryngeal surgeries with what do you call this, with apneic oxygenation. So I kind of started doing this. We have a small number of patients. Currently, the ENT surgeon that we had shifted, and we got a new ENT surgeon. We still, apparently he's still waiting for his laser equipment, and then once we have laser equipment, we'll probably will start doing it. Okay, just to document what happens, you could see that this is just the start of surgery. You just take note of the time, 9:24, and the BIS, you can see that the patient is still about sedated, going into anesthesia. And we were running TIVA, of course, with the high flow system. And you can see 9:28:47, the patient is under anesthesia, paralyzed. Okay, and the saturation, just take note, still 100%, 9:39. So this was what, about from the start, which is 24. This is about 15 minutes or so, and then eventually 9:41, which is about 20 minutes. Sorry, a bit coming to 20 minutes, and then when the surgery was over, I put the LMA now and reversed the patient. So you can see that even for a short, even for this kind of 15-20 minutes, patients safely do not desaturate. Okay, the only time I find that when they desaturate, particularly if there is, when they're doing laryngeal surgery, when the surgeons are doing laryngeal surgery, is when there's actually hyperextension. So particularly in children, I find when there's hyperextension, there's going to be some degree of obstruction, and then this is where the patients start desaturate. So for most of the time, if there's actually a patent airway and the high flow system is actually well positioned, then there's actually going to be a delayed desaturation up to 20 to 25 minutes or so. Okay, so these are the uses for apneic oxygenation. When in some surgeries where you don't want to move the lung, diagnosis of brain death, cardiac arrest, and extracorporeal carbon dioxide removal. The complications, one of the things that have been probably, it's probably too small for you to read, is one of the concerns that they have is actually fire. So in places, of course, I haven't done much to actually share quite extensive experience, but when Imran Ahmad was talking, one of the things that he does whenever they're using laser is that they will bring down the FiO2. So when, like most situations when there's no laser involved, you can safely use 100%, but when laser is being used, maybe you want to reduce the FiO2. So because of the fact when you reduce the FiO2, so the apnea time will be shortened. Okay, I'm just going to highlight one of the things that I think it's quite useful is actually awake. For apneic oxygenation is awake fiber optic intubation. So this is one of the NAP4 projects. So basically, RCOA, Royal College Anaesthetists, will go into this cycle every few years. So the 2011 one was looking at intubation, and one of the things that they highlighted was that when in cases where the airway was lost and resulting in morbidity and mortality is when there was actually strong indication for awake fiber optic intubation, but it was not actually employed. So I'm just going to, this is our standard DAS guidelines. I think most of you are well aware of this. I won't go into great detail. Okay, but just to highlight this ASA one. So the one in the actual box is actually intubation with awake patient. And when you have all this suspected difficulty, ventilation with face mask or supraglottic device, significantly increased risk of aspiration or increased risk of rapid desaturation, the ASA recommends that you do awake fiber optic. All of you are using awake fiber optic on a regular basis? Okay, so basically, the DAS published this a few years back. It's quite interesting. So they've got 4 basically things that we need to consider. Okay, and then this is the ergonomics. Okay, the first thing is actually the oxygenation. So I'm sorry about the crop. Yeah, this is the Mac and thing, the Mac and PC thing. So the one thing that they recommend is actually using high flow nasal cannula and maintaining it. Okay, why particularly is that because of the fact that we run some sedation and we run REMI. So if there's any event, in the case of the patients go a bit bradypneic or even apneic for a certain period, usually they won't desaturate. So this is kind of interesting. That I think something that because I think most departments will have high flow nasal cannula available. There's something that it's quite easy to actually employ to do. So in terms of the drug, of course, the propofol and things like that, you may or may not use, but personally, I find that we just run high dose REMI, and sometimes the recommendation, even in DAS, is 3, but I sometimes use 4 to 5. And provided you don't use anything else, and patients usually don't desaturate that much. Okay, and then a bit of a thing, something on topicalization that at least DAS recommend, and a bit of my experience is actually I've started using this Magic, which is available to us, and the xylocaine spray. So I find that the ones that I use, and I use VL awake, video laryngoscope awake, is that you anesthetize the tip, the base of the tongue, and then once you put the laryngoscope in, you use the Magic atomizer to actually anesthetize the vallecula. You put in the tip of the blade into the vallecula, and you use the atomizer to actually anesthetize the vocal cord as well as the trachea. So basically, this is a documentation of this is a video. What I did was actually this was a awake patient, so the blade, the VL is in the vallecula, and I kind of I negotiated and put and atomized the local lignocaine to the vocal cord and initially, and then put it through the trachea. And you find that if you do it well, with with a small dose of remifentanil, you don't get a lot of gagging when you put the tube in. So again, it's actually, this is, I think now with the availability of VL, I think it's something that we should consider instead of fiber optic intubation. This is just a documentation of, this is an awake patient. You could see that the vocal cord is still moving and is still breathing. We're still talking to the patient. We're using some degree low dose, basically high dose REMI and low dose propofol. The 0.1 is mainly so that, this is in the system and it's much easier for us to, okay. This, we had, for this particular case, we used, we didn't use the Magic system for airway topicalization. You can see that even in an awake patient that there's very minimal gag if you prepare them quite well. Okay, so we know now that there's enough evidence. This is actually meta-analysis showing the VL and fiber optic awake bronchoscopy, and in this particular meta-analysis that show that actually for VL awake, it's much shorter time compared to actually the fiber optic awake intubation. Okay, but just to when I was looking around at the incidence of awake tracheal intubation, this was quite interesting. This was published in CJA, Canadian Journal, and they were looking at one single hospital, and they were looking at data between 2014 and 2020, and there is actually documentation of the basic reduction in the incidences or in the cases of awake intubation. This may be true because of the fact that there's a lot of VL and more other equipment available. So things have basically most of possible difficult airway are being done within the general under general anesthesia. So again, just to recap this again, if you are to do awake, then probably it's best to provide them with high flow nasal cannula as well as high flow system, as well as possible considering an awake VL. This is actually, I can plead. Okay, so this is actually a combo. I think this tomorrow's speaker will probably talk on it, but this is under GA. So, or is it? Oh, sorry, this was an awake patient, yeah. So we can combine both, yeah, it's probably a short video. We kind of combine both the VL and used the fiber optic. So the documentation of this technique is very new. So something that you guys may want to consider. So the VL I find does actually open up the whole oral pharynx, and it's much easier to actually put the fiber optic in the mouth. Okay, this is to take home if you like. And I think eventually the skills may or may not. I think because of the most of the time we may not be doing it. I think the skills of awake fiber optic intubation is probably going to be lost. But I think most of you are responsible of training at various levels. So something that you guys can consider. This is actually a UCL training where the participants do awake fiber optic on themselves, because if they can't. But these are just fiber optic without actual anesthesia. So if I can conclude, I'd just like to quote this particular paper. Apneic oxygenation can be employed in diverse clinical settings. It holds promise in hypoxemia. Enthusiasm of apneic oxygenation needs to be accompanied with healthy caution and greater degree of scientific rigor, and further assessment is needed regarding which subpopulations are most likely to derive benefit from apneic oxygenation. With that, I thank you. Thank you.